Great. Thank you very much. We're going to kind of work through our speakers, and then we'll have Mr. Bond to present the bill, and then we'll have questions from the members here. So next, Sarah.
Yes.
Great. Thank you.
Good afternoon. My name is Sarah Muller. I'm the Vice President for External Affairs with the California Association of Public Hospitals and Health Systems. Thank you, Mr. Chair and members of the committee. We're very excited to be here. What I'd like to do is just very briefly talk a little bit from a public health care perspective what the waiver means to us and what some of these programs will look like on the ground as they really unfold over the next couple of years. First, just to give you a quick sense of who are the designated public health care systems, they are the county-owned and operated hospitals in your communities and the 5 University of California medical centers. They are a small but mighty group, I would say. There's only 17 of them, but together are the major safety net providers in their communities and also serve a number of other critical functions. They provide a number of critical services that you won't get anywhere else, whether that's highly specialized care, burn services, trauma care, that sort of thing. And in addition to that are the major educators for our next generation of doctors. Together they train just under 60% of the next generation of physicians. And so even if you don't get your care in a public hospital, chances are your doctor was getting trained by one. As major participants in the 2010 waiver, the public health care systems really took some time leading up to the 2015 waiver to think about how we could be supportive of the state's efforts in a 2015 negotiation and what some of these programs could potentially look like from our perspective. And we really started with a place of thinking about where our systems needed to be in 2020, what that care should look like, and the role that the waiver may be able to provide in helping support those efforts and get us there. And collectively, we developed a mission statement that was very focused on how we can become integrated models of care with great patient experience, high quality and access, and become increasingly responsible for not only the health care, but the overall health of the populations that we serve. And you'll see a lot of those themes in some of the programs that I talk about this afternoon. The other element of this was we really wanted to build on the success of the 2010 waiver. As Ms. Cantwell talked about, the low-income health program was incredibly successful in launching our Medi-Cal expansion, and the district program, or the pay-for-performance program for the public health care systems, was critical in laying that foundation. It allowed us to make sure that when people signed up for Medi-Cal, they could get access to an appointment. They could see a primary care team that was organized and working together to improve their care. And we really wanted to build on those experiences. And that is exactly what the 3 programs I want to highlight for you today really do. The first is the PRIME program. And Ms. Campbell talked a lot about kind of the elements of the PRIME program. And I'll just underscore that I think of PRIME as not kind of 2.0 for the district, but as kind of the next chapter out the door and around the corner. It is much more challenging, much more standardized. We will be held to a much higher expectation in terms of success and in our ability to leverage that federal funding than we were in the last few years. There's also a much greater focus on clinical outcomes and year-over-year improvement. So if we knock it out of the park in year 2, that doesn't give us a free pass for year 3. We have to keep building on that success and year-over-year continue to get better. So what does this mean for patients on the ground? Let me give you 2 patient examples. Lori is a patient of ours in Los Angeles who's been going to one of our clinics for a number of years. And through the district, she was enrolled into a medical home and got a primary care team that was all working together to coordinate her needs and make sure that she could get appointments when she needed them. Under PRIME, our federal funding will now be contingent on demonstrating Lori's health has gotten better. How good are we doing at managing her diabetes, making sure she's receiving her scheduled mammograms, screening her for depression if we think that that might be something she's struggling with, helping her stop smoking if she's a smoker, and capturing her race, ethnicity, sexual orientation, and gender identity information so that we are together starting to identify specific disparities that Lori and many of our other patients may be struggling from. Stanley came to us through the trauma center at Alameda Health System, and we saved his life. As part of his recovery through the DSRIP, Alameda Health System really worked to coordinate both his inpatient needs and his outpatient needs in order to enable a safe recovery and improved health for Stanley. Now, through the PRIME program's Care Transition Project, all of our systems will be expanding on these efforts, and our federal funding will be based on making sure that Stanley and other people like Stanley are not readmitted to the hospital, making sure that when Stanley and others get discharged, they have all the information that they need so that they can continue along their recovery journey at home, and making sure that the providers that took care of him in the hospital setting are coordinating with Stanley's primary care team so that all the follow-up appointments and needed medication can continue and make sure that he has a strong and healthy recovery. So that's PRIME. Global Payment Program is another exciting opportunity for the designated public health care systems. As Ms. Cantwell described, this is a reorganization of existing federal funding that we have received in the past. Much of it was focused in the hospital setting, but the Global Payment Program allows us to really redesign how we're providing care exclusively for the uninsured in our communities so that it is really targeted at where care is needed in the appropriate setting. It allows us to expand ambulatory care and primary care services. It incentivizes us to provide non-traditional services where we currently have little or no reimbursement. So those would be care navigators, health coaches, nurse advice lines, important services that we need to be able to ensure good access for our patients. And it also supports the continuation of traditional services as they exist. As much as we want to expand ambulatory care, sometimes people end up in the hospital, and this program continues to provide support for those services as well. The public healthcare systems are in the midst of designing their global payment programs and really thinking about how they can build on their prior lessons learned from the low-income health program and what redesign is necessary in their communities so that they can provide really efficient and coordinated care for our uninsured patients. The last program I wanted to touch on is whole person care, and every time I think about this I get excited. It is a new program in the waiver that really builds on the strength of the heart of our local communities in California and our local counties. It supports a level of collaboration, care integration, and data sharing in a way that we probably have never done before. It moves us away from just thinking about coverage to really getting our arms around the most high-utilizing, high-cost patients that we have in our system and really trying to provide individualized care plans for those patients. Our public health care systems have already started working with a number of their local partners to start to think about how to design these programs. And I'll just give you a sense of some of what they've learned so far. One of our members ran their kind of top 1% of hospital users, and of those, 70% were homeless. More than half had been in contact with the mental health or substance use services. 70% had at least 3 chronic conditions, and 22% had a record of being in the jail health system in the last 12 months. So there's a lot of really exciting work happening to try and think about how we can provide much better coordinated care for these high-risk patients. All in all, there's a couple of key takeaways I really want to share. First is all of these programs really demonstrate California's leadership. The leadership of Ms. Cantwell and the Department of Healthcare Services in securing an innovative waiver that really is piloting a number of exciting programs, some for the very first time. There are a lot of really exciting opportunities to make critical investments in not only how we deliver care for our patients, but in improving the health of all of those that come to our systems for services. However, I will say this work is ambitious and it is challenging. We are fully well aware of how much harder this work will be, but are fully committed and embracing that challenge, as it is not only the work that we want to do, but it is absolutely the work that we need to do over the next 5 years to improve the health of our communities. Thank you.
Thank you very much. Sharita?
Yes. Mr. Chair and members, I'm Sharita Lane, Vice President for Finance Policy for the District Hospital Leadership Forum. Thank you very much for inviting me to be here today. All the participating district and municipal hospitals are very enthusiastic about PRIME and are grateful to be included in it, and also grateful to be able to work with folks at the Department of Healthcare Services that have been working tirelessly on this program both now and in the prior waiver. We also owe significant gratitude to our colleagues at the California Association of Public Hospitals, both the association and their member hospitals. They've been very generous in sharing the lessons learned in DSRIP 1.0 and some of the pitfalls that might lay ahead in this program. The District Hospital Leadership Forum represents California's 40 district and municipal public hospitals, as Ms. Cantwell said, previously known as non-designated public hospitals. These hospitals have publicly elected boards of directors. They are local governments responsible for providing the healthcare needs of their communities or / their district. These hospitals are very diverse. They range from very small, like 3 acute beds, to the very large, greater than 300 beds in suburban and urban areas. The services are also diverse. Some of those very small hospitals provide, like I said, have a very small acute unit, but may have an array of some rural health clinics and provide some long-term care services. And then the larger facilities provide somewhat similarly to other hospitals, including the county and UC hospitals, trauma and tertiary. These hospitals are located in 28 counties throughout California. I believe you just got a map. They are from San Diego and Imperial County in the south to Modoc County in the north. 2/3 are rural, and 20 of them have a critical access hospital designation. As Ms. Cantwell noted, these hospitals were not included in DSRIP 1.0, but we are now committed and ready to take on this challenge and are very appreciative that DHCS recognized the need among these facilities to participate in a program that would help us transform for the future. Like I said, since then, these hospitals have become very organized and put in place some of the groundwork in order to move forward. Almost all of these hospitals are participating in Prime. There are 2 that are not. The most smallest and most fiscally fragile is not, and then one that is changing ownership type to a private hospital, like momentarily. The very smallest are working on 1 project, as Ms. Cantwell mentioned, and up to 11 projects for the very large. Each of these hospitals chose projects that would allow the hospital to be in the best position to serve their own individual community. So it's based on their community needs. For example, there are a couple of our hospitals that are located in areas that have a high number of extreme sports. They're putting in place non-malignant pain management clinics. Some areas have noticed a gap in cancer screening, so they're going to work on that project. And a number of the rural areas especially, they are the only healthcare provider in the area, and so they're going to work on prevention since that's where most of the residents go to get some of their preventative services. I wanted to mention just a couple of the challenges and differences between the districts and the county and UC hospitals. First is that district and municipal hospitals cannot hire physicians, and that's been a challenge. But with Prime has come, I believe, an opportunity where they have put in place some arrangements so that they can ensure that participants in Prime and the rest of their patients are able to receive primary care. And then the other point is one that we've touched on, which is that these hospitals did not participate in DSRIP 1.0, and so need the ability to use infrastructure measures in order to ramp up, to get ready to actually start the work of Prime to measure their performance. And we're very grateful to DHCS for recognizing that need and including that in the construct of this program. Now that the applications are in, the hospital's attention turns to implementing the projects, and we're very excited to be working both internally together with our colleagues at CAPH and their member hospitals and with the department. We also, as Ms. Cantwell mentioned, the alternative payment methodology does not apply. The requirement for that does not apply to district and municipal hospitals, but we are planning for that since that's the way that's the way of the world. And so we're beginning to plan for that end game and how to use Prime to get to where we need to be. In closing, we're very appreciative of the partnership with DHCS and the support of members here in the legislature of including these hospitals in the waiver and in this important program. We look forward to the application approval and implementation of these exciting projects that will benefit Medi-Cal beneficiaries in these communities throughout California. Thank you.
Thank you very much. Ms. Brooks.
I'm Kelly Brooks, and I'm speaking today on behalf of the California State Association of Counties, or CSAC. CSAC is very pleased to be here in support of the measures and Medi-Cal 2020. The association supports all of the elements of the waiver, and I'm speaking particularly about whole person care this afternoon. The whole person care pilot that's included in the waiver is really unique. It's the first time that a project focused on the just social determinants of health has been included in California's Medicaid waiver. I think it's a really unique opportunity, and frankly, the nation may be watching for a Medicaid program to think about how it can affect health outcomes, looking at the broader system and a broader set of actors, not just Medi-Cal managed care plans, but different parts of county government, so health agencies, specialty mental health providers, perhaps the jail, perhaps substance use disorder agencies, perhaps even emergency medical services, but really looking across systems and seeing how entities, public and private, can coordinate, use data in real time to think about how to provide better services and, in the end, improve health outcomes for a specific target population. I think one of the sort of ideas walking into whole person care was the realization that no one entity was going to achieve the triple aim or improve health outcomes by themselves. The growing recognition that public and private entities need to work together across systems to really achieve the outcomes we want to see for some of our hardest to serve patients. And so I think that sort of underlying goal and opportunity is really what whole person care is all about. I would be remiss if I didn't thank the Department of Healthcare Services for their work and advocacy on this element of the waiver. When we started discussions back in 2014, whole person care was sort of a brainstorm idea and perhaps wasn't even included in their initial plans. And the more we talked about it and realized how there was a lot of symmetry between what the department was thinking on housing, that this became sort of a cornerstone of their waiver proposal. And so we're very pleased with the collaboration that we've had with the department over the last several months. I would also like to recognize the partners that CSAC has worked with over the last year and a half in trying to get this idea of whole person care into something tangible and real. We've worked quite a bit with the and frankly, it's a collaboration with the county or the California Association of Public Hospitals, with the county health executives, with the county behavioral health directors, with the county welfare directors, with the local health plans of California, with the Corporation for Supportive Housing, and with SEIU California. We've been partners throughout all of this, and we are working quite a bit with local entities that are interested in bringing whole person care pilots online and have offered a little bit of technical assistance as a group. I think counties are very excited about the whole person care opportunity. It builds upon some of the work that counties have done with the low-income health programs and with the predecessor, the coverage initiatives. And so I think counties feel like they have some of the tools ready. They understand what it means to participate in a waiver. They understand what it means to be part of an evaluation and how to think about designing a local pilot and to be focused on health outcomes. I think the other thing that is important that I think Ms. Cantwell touched upon really briefly is that I think as folks are heading into thinking about how to design their whole person care pilots, is they think about sustainability, so that the pilot is an opportunity to create infrastructure, collaboration, cooperation amongst multiple entities, and have it sustained beyond the life of the waiver. So the idea is that you would use data to identify a target population. So who are your high utilizers of multiple systems? Who's calling 911 a lot? Who's going to the emergency room a lot, who is showing up with significant behavioral health needs. And so having that drive the local discussions about who are the actors within your pilot program, and then thinking about systems that you put in place to allow you to really look at this population and then how you're actually changing health outcomes. I think the opportunity is really unique and exciting. I think the other interesting thing that we have at this point in time is there's a lot of other pilot opportunities and discussions going on at the state level that will allow locals to sort of maximize what they're going to do in the pilots. So you've heard a little bit about the PRIME projects. I think that there is going to be some symmetry between what some of the hospital sites are doing with PRIME and what could go on in whole person care. I think folks are looking at the health home projects that are going to start to be implemented in 2017 and thinking about how those things fit together. I think counties that are contemplating participating in the drug Medi-Cal waiver are thinking about how they can leverage these opportunities to work together. And I think the conversations that the legislature is having about housing and homelessness is another opportunity to think about, okay, how did the different pieces of the puzzle fit together? I think I would be remiss if I didn't talk a little bit about housing. It's a very unique opportunity, and again, DHCS needs to be applauded for their work in trying to get funding to allow Medicaid to cover some housing supports. CMS issued guidance in June of 2015, and it's a pretty expansive list of things that we are going to be able to draw down Medicaid match for in relation to housing supports. And I think this is really going to that piece of it has really driven, I think, local interest in thinking about how they might structure a program and what kinds of services they might provide. So things like recuperative care, sobering centers, how they might use peer support navigators to help with transportation and getting to appointments. I think those are the kinds of things people are thinking about as they start to plan their whole person care pilots. And with that, very pleased to be here and in support.
Great. Thank you very, very much. I appreciate all the presentations. And if you guys want to just hang out, I'm sure we're going to have questions from the folks. Mr. Bonta?